You folks that come beyond me. Well, good morning, everybody. I'm Tom Carroll from Mercy Health St. Mary's. I'd like to welcome you to our Employers Council meeting this morning, and it would probably be fitting. We do have a big group today to go around and do introductions. Eric, do you want to start?
My name is Eric Keller. I'm with an organization called Mad Dog Data Science. That's the whole story. We can talk later. But I do some work for the Alliance for Health to help coordinate these meetings.
I'm Lodi Zworenski with the Alliance for Health, and I might as well take a moment to introduce my sidekick here. I had the pleasure of hiring my heir apparent at the Alliance. You know, the demographic imperative is coming. But Paul Brand down here in the bluish shirt is the Executive Vice President of the Alliance. He comes to us most recently from Rockford, Illinois, where he was the head of ECO, the Employers Coalition on Health, where they put together an employer-owned health plan and had the distinction of having one of the first Prometheus payment models in the nation run through their employer coalition. Before that, Paul was the head of the Real Health Association here in the West Michigan area, where he put together an employer-owned payment and health plan concentrating in the Muskegon, Holland, and Grand Rapids area. Before that, Paul tells me he even habituated the halls of St. Mary's here several years ago, so familiar with where we are. But Paul, as I said, will be my heir apparent at the Alliance. So hope you'll all have a chance, if you haven't already, to meet him.
Hi, I'm Karen Daly. I'm the Dean of the College of Health Professions at Davenport University.
I'm Mary Menchinger. I'm the Director of Nursing for Cherry Street Health Services, and Mike Reagan asked me to come today, but I don't see Mike.
That's why he asked you to come.
I think that's why he asked you to come.
I'm Susan North. I'm from West Shore Community College up by Ludington, and I'm the Director of Nursing and Allied Health.
I'm Brenda Paul. I'm from the Office of the Vice Provost for Health at GVSU. Jean Nettleker.
I'm Chad Tuttle. I'm the CEO at Sunset Retirement Communities and Services. We had been previously engaged with the Employers Council in the past and are re-engaging at this point due to some strategic growth plans in our organization. But I also want to introduce, I brought a guest, Chelsea Bojic, who, one of my other hats, I'm one of the coordinators and instructors in the healthcare MBA program at Cornerstone University. Chelsea's a recent MBA grad from that program and had expressed an interest in the collaborations that are going on in the healthcare industry, and I offered to expose her to what some of those collaborations are. And also point out Chelsea is looking for her entry point into the industry as well.
I'm Louise Jacobs. I'm the HR Director at Network 180, which is Kent County Community Mental Health. Amy Eady, Dean of Health Occupations at Montcalm Community College. Good morning. I'm Fiona Hurt from Grand Rapids Community College, and I'm Dean for School Workforce Development.
Good morning. My name is Jason Boomer. I'm a Director of Compensation for Metro Health.
I'm Mary Hughes. I'm Vice President of Human Resources at Metro Health.
I'm Paul Brand, and I'm the smile on Louie's face.
Good morning. I'm Chuck Colress. I'm on the administrative team at Holland Hospital.
Thank you and welcome. Is Kevin going to be joining us?
Kevin is not. I've got his presentation for him.
Great.
So I guess it's on me, right?
It's on you.
And I'll just say we're trying something different, so please bear with us as we adjust this technology. What we're attempting to do is upgrade. We have this available on GoToMeeting for people to attend remotely, and there's now a feature in GoToMeeting where you can record the meeting, the visuals and the sound, and then send it out like on YouTube, post it on YouTube. So that way people who are not able to attend or who maybe they can just get online with the phone but not on the computer, they'll be able to actually see the meeting. So that's why things are a little jumbled up here this morning. I apologize for that. Kevin Stotts was not able to be here, and I have his slides up here on the computer, but I can't show them because they're working on that right now. But there was a handout, and I don't know that I printed enough of them, but there are 2 handouts from Talent 2025. And what I'm going to do is I'm going to summarize a meeting that took place and now my computer's frozen. So I can't see my slides. Oh my. I apologize.
Well, we could take a couple minutes while they're finishing up with the screen up front. And,
Can you get to the slides from here? I can hook your laptop in like this if we scooch.
Oh.
If that's all right.
Yeah, that'll have to do, I guess.
So we can just upgrade it to get to the meeting.
That's, oh, okay, good. I like it. That'll probably work just as well because I think, the GoToMeeting is a whole thing in and of itself, so. So here's our agenda. Just told me my computer was overloaded. That kind of seemed obvious, So what we're going to do today, I'll just go through the agenda briefly, is we're going to talk about the Talent 2025. This is a labor planning and a forecasting update, and I'm going to give you an update from Kevin Stotts. Kevin sends his apologies. He's short-staffed. He had a couple people leave, and so he's holding down the fort, and sends his regards. They had a meeting last week, and Craig and I will be attending the future meetings, and they convened a number of people, and that's what we're going to talk about in his presentation. I'm going to give it won't be 10 minutes, maybe a 30-second update on coaching. Then the meat of this meeting is really to talk about the results of a knowledge, skills, and abilities survey that was done from the members on medical assistants, and then to talk about the medical assistant scorecard or report card, which we have an updated version of that, which there were copies of. And then we'll talk about the next occupation for study, have some discussion on that. So that's really what we're covering today. My overloaded computer. Maybe I'll just leave it here. Not as pretty, but at least I can go through the slides. So there are meeting notes from this past meeting and a diagram. And the state has hired an economic analyst to work on labor planning and forecasting. His name is Ryan G. Mark, and he is working for Jason Palmer with the state. And I know everybody who's met with Jason said he's really excellent. He's been doing a lot of work for the state, what used to be called D-Leg, for quite some time. The director, Christine Quinn, is supportive of working with West Michigan. Her position is that they think the state is doing a good job of labor planning and forecasting, but they are willing to work with different regions to try to tweak things. So while I don't want to lead you to believe that Ryan is assigned to work on this exclusively, that's not the case. But they will work with West Michigan to try to add some, I guess, granularity, I'll just say, to our labor planning and forecasting. The focus that Kevin really wants is for this to be a demand forecast looking into the future, not a rear view mirror kind of forecast. And they will be following a KSA format, or a knowledge, skills, and ability format. That's what they're looking at. If you look at the different, and again, Kevin wants this to be a real-time data forecast for talent. And then I might add, this is not just healthcare. They're looking at major sectors. So it would be healthcare, manufacturing, probably retail. Agriculture is the second largest industry in the state of Michigan. So agriculture would be included, and probably energy, some other industries like that. There's about 8 or 9 that they're focusing on.
We might spend a moment on the regions. Governor wanting interest in supporting regional approaches to.
I'll let Lodi cover that, yeah.
Okay.
Because he knows more about it than I do.
Just as a matter of background, the governor has put out his desire for the state to regionalize in just about all approaches. Public health is being asked to form regions, mental health is being asked to form regions, and then work together to integrate those. Governor's gone so far as to say he'd love to have school boards integrated on a regional level, but most authorities of the state, the economic planning and so on, is regionalizing, and among those that are regionalizing are the workforce development boards. They, at the same time, are under pressure to form sector councils, and this group right here is a regional sector council when it comes to the healthcare sector. So we've invited all of the Michigan Works agencies to come back and be an active part of this group as a healthcare sector council. So it's a ready-made add water thing. The governor there's an opportunity for us, and you should be aware of that. The governor wants successful results, because nothing worse than having people fight and so on. This is viewed as one of those prime successes. So from the state perspective, it's kind of add water, just add water and watch it grow. So being able to but ask Ryan to help quite a bit here is not out of line, because this is one of their priorities from which they can get some very early successes that they can then use as a model for some of the other sectors that have to get together. So we have opportunity.
Thanks, Lodi. Lodi's been in touch on this regionalization through the governor's office, so he knows a lot more about it than I do. The last point about that meeting that Kevin pointed out is they had good representation from economic development and Bill Raymond from Ottawa County. Michigan Works was represented there, representing the 5 regions, the 5 different Michigan Works agencies. And so I know that Bill Raymond committed some funds for a person to act as a coordinator for Talent 2025 to help with these forecasts. So this individual would work for Talent 2025, and they would be a liaison with Ryan at the state. And so the person locally would go out and help employers collect the data, and then work with the other partners, the education organizations, the other workforce agencies, and then also other economic development like the Right Place. So things are falling into place. There is a diagram here. It's just a delay. And, they want to be high touch with the employers. They have this crunch team, advisory panel. They're calling it a WIN or organization. On the tech side, the state has invested significantly in that they added something called EMSI. It's a labor planning and forecasting system. We had looked at that a number of years ago. Then they went and added Chimera and Burning Glass. Craig and I are familiar with all 3 of these labor planning and forecasting systems. And they do some very interesting things. The state of Indiana, for instance, is way ahead of the state of Michigan and other states by partnering with Burning Glass. They have set up, this is all set up in Indiana, so that actually an individual looking for a job would be hooking directly into the labor planning and forecasting of the state of Indiana through a portal, and would be able to look for currently posted jobs all over the state of Indiana in, say, healthcare or manufacturing, down to a position level. And they do that using a web crawler. The web crawler goes out and finds all the jobs posted in the United States in the sectors that they're interested in, and then it compiles all that, and it does it based on a knowledge, skills, and ability kind of a format. So it has a rudimentary job description with the most important elements. And Burning Glass really has the best technology around that we've been able to discover. So that's kind of the tech side, where they're going to be feeding the information in, and then the reports will come out. The next steps: attempt to fund a part-time position. I updated you on that. Develop an estimate of available funding for West Michigan WIN effort. That's a broader effort than just the labor planning and forecasting. It is similar to what we are doing as a healthcare employer council, but through Talent 2025 for all industries. And this had been proposed early on, right after the Wired grant, and that's really the way Talent 2025 had been intended to be set up, as I understand it. They'll be developing a case statement for West Michigan WIN, and then convene a team of practitioners to develop the framework and then do the organizational structure. And these meetings are supposed to be occurring the rest of this month and early next month. So I would expect by our November meeting of this council, we should have a significant amount of information on this effort, and probably a person in place to start to help us with that forecasting. So for those of you who are maybe new to the council or have only attended recently, I think this is our 23rd consecutive quarterly meeting, so we've been meeting for over 5 years as a group, and we had two main areas of emphasis originally. One was around career coaching, and then the other was around this labor planning and forecasting. So both of those efforts have now significant legs. We have a lot of partnership going on. We've tried to do our own labor planning and forecasting as a group. It's very difficult to do. You really need to have the kind of committed resources that Talent 2025 is talking about in order to make it work. And so I'm very pleased that we have this partnership going on with Talent 2025. So we're going to be talking about, since we've now making significant traction on these two big projects that our council was designed to work on, we are now moving to new areas, which is this report card on high-velocity occupations, and then also the knowledge, skills, and abilities for high-velocity occupations in healthcare. So we'll be talking about that next, but I'll stop and just ask, are there any questions about the Talent 2025 or the labor planning and forecasting?
Here's a question most people probably know the answer to, but I don't. What does WIN stand for?
Do you know that, Lodi? WIN, there's an organization on the east.
Correct term.
There's an organization on the east side of the state, and I tried to look it up on the internet last night, and so I don't know what it stands for. But Kevin Stott from Talent 2025 has been attending their meetings, and it is, I would call it kind of an Alliance for Health kind of organization, but for multi-sectors. So it's very similar to what Lodi's and Paul's organization do, but again for all sectors. And so Kevin is trying to pattern a lot of his efforts in West Michigan for Talent 2025 around this WIN infrastructure, and then he'll be able to partner with that other organization on the east side of the state. I will find out what it means, but
We'll get there's a whole series of new acronyms along the line of, success for the future and winning strategies of this. Anyway, there's several of them coming down. We'll give them to you because you got to keep up with the acronyms.
Here, do we want to move on to the
Yes.
coaching?
So career coaching, this will be about a 30-second update unless Tom might have something. I did not get an answer back yet from the group that's working on the web-based coaching, but I believe that was due to be completed. It's a web-based coaching model. It was due to be completed at the end of July, and a pilot started at Mercy Health Systems. The pilot, I believe, Tom, was going to be about 15 or 20 people. It would be some leadership people, some organization talent development folks, and then also some real users who want to go through career coaching. It's a completely interactive, self-paced career coaching model that can be supplemented with a live coach if the person desires. And so that pilot is probably underway at this point. As soon as that pilot is done, then it will be launched West Michigan-wide for Mercy Health Systems. And the employer council members will have access to that. The organization that's doing that work with Trinity has graciously allowed the Healthcare Employer Council to also utilize that website. So I should have a lot more information in November. I believe it'll be fully launched at that time, and it's a much, a career coaching engagement costs an organization about $500 to deliver. We did have a grant from the state where we were able to pay for 50% of that, but unfortunately the funding ended early. This coaching model costs a fraction of that. It's just basically paying for access to the portal, and then it's the person's time, which they can do that either from work or from home. And again, they can hire a coach, but they don't need a full-time coach. It just would be if they need some extra help.
So is this in place of the other thing that you guys were involved in? We had tried it, Network 180 and had a couple people go through too?
The program that you went through, Louise Yautz asked about if is this the same as the earlier program. That was the program with the live coach, and it costs, we actually charged about $400, and the state paid for 50% of that. That program is over. We took all that information from that coaching model and all the learning, and we incorporated that into a web-based coaching program that's delivered using new MOOC techniques, massive online courses that a lot of the universities are doing now, or using those kinds of techniques to deliver that. And ACT is actually building that.
And then you guys are trying it as a pilot? Is that okay? So you'll tell us whether it's any good.
It'll be outstanding.
Okay.
Yeah, I think it's going to be really good. Yeah, it is exactly the same content as the
Is it ready for other people to use yet, or does it have to go?
It needs to go through a pilot phase. Yeah. Yes.
I'm just interested in that career coaching. We look at that from an educational standpoint, even before they choose which health career they might want to go into.
Right.
Would it be appropriate for that, or is it, when people are entering the workforce with a degree in hand?
It's most appropriate before they even get started. That's in Tom's case or the employer's case. You have an employee that you're trying to do career development with.
Mm-hmm.
But it also is extremely useful and is designed for maybe a high school junior or senior to go through to determine what field is it that I would be best suited to go into. And the focus of it is on the individual's interests and values, or what we call fit. And we've learned over the years, and ACT has validated this through extensive research statistically, that the single best way to match somebody up to a career is through an interest match, their personal interest with the job. There are other things that are important, and so that's the first step, is find out, is the person a good match for that job, from a personality and a values and an interest standpoint. And if they are, then let's do some testing and see what kind of educational skills they need to build and in what areas, so that they can handle the curriculum, and then that prepares them to go into the curriculum. So people may need some remediation. It does point out if the person needs maybe some math remediation or other kinds of remediation. That's not available in the coaching, but there are other resources for people to access that. Does that help?
Yeah, very great.
And we can talk more about that. So, any other questions on coaching? That was longer. I lied, but good questions. So, thank you. All right, the KSA surveys. This was really interesting. We got a very good response on the KSA survey. It was a very simple questionnaire. Essentially what we did is we went into the ONET and we listed out all the knowledge, skills, and abilities of a medical assistant that were listed in ONET, and we already had information from Mercy Health Systems. Am I using the term correctly, Tom? Mercy Health System had done a job profiling analysis on medical assistants, so we knew which knowledge, skills, and abilities were important to Mercy Health. Then we wanted to supplement that with information from other healthcare providers that have medical assistant positions that they employ, and not everybody employs that position. So we did not expect it to be, everybody in the organization here, the council. We received then responses from Cherry Street, Holland Hospital, Metro, and of course we had the Mercy Health, and then Spectrum. And I roughly added this up. I believe that it represents at least 18 different locations in West Michigan. By the time you add up all of Spectrum's facilities and all of Metro's and Mercy Health's facilities, and Holland has several facilities. So I believe it was at least 18 locations. That's hospitals, clinics, medical practices, and some extended care. You should have that survey in front of you, and I'm really sorry for the size of the type, but the responses are there. This is, in a very crude way, ranked. What I did is we had people check on the survey the knowledge, skills, and abilities that were most important or were important in their organization, and then rank from most important to least important. And then what I did is I tabulated and then did a ranking of the total tabulation. So it is a bit crude because there are some, for instance, knowledge areas that some organizations feel are important and others don't, but everything is listed here. So you do have it in a rudimentary ranked order. I'm going to ask Andy Catlin, who's our data whiz, to take a look at the raw data and see if there might be a better way than my approach. But I'm pleased that we've got a very nice look at what the important knowledge, skills, and abilities are for a medical assistant in West Michigan. And I feel this information should be extremely valuable to the educators, because you kind of know then in mass what are the things that the healthcare organizations are looking for. I used a term a couple of times called high velocity occupations, and I know we have a number of new people, so maybe I should explain what a high velocity occupation is. The work that Tom has been doing in his organization, and he can clarify this, I'm going to give you a real high level, is that they know that they have about 15 to 20 occupations that comprise probably 60% of their total work population. So it's a Pareto kind of principle where you may have 150 jobs, but there's 20 of them that are the bulk of your population in your organization. Of those 20, there's probably 10 or 12 that you do the most hiring in. And so we're calling those high velocity occupations. Those are occupations that a lot of interviewing and hiring goes on, and we want to try to make improvement in the retention of those positions so that you get a longer retention period and you save money and you deliver better patient care results because you have more consistency in your organization. There's a whole lot of benefits, and so that's the whole purpose of providing this information to the educators, collecting it from the employers, and then the report card that we're going to talk about in a few minutes. Medical assistant was the first high-velocity occupation that was chosen, and we're going to talk about what the second one is. And part of the reasons is we felt it was manageable for us to be able to, handle first shoot out of the box. It was not overwhelming. There are not thousands of medical assistants, but there are a lot of education programs. So a lot of organizations hire medical assistants, and then there are a lot of education programs around it. So we thought that would be a good first starting point. So are there any questions? By the way, all these materials will be sent to everybody. I'm going to hand a sign-out sheet out in case I miss anybody. But we will send all this out, the actual documents, and then you'll get a YouTube link to this particular video as well. Yes?
I'm an RN. When I look at this list, especially in the knowledge portion, it looks like something that I would expect from an RN grad. But I know that a medical assistant, I've spent more time than I wish I was looking at the curriculum because we're developing a program, and I'm not sure that everything on this is exactly what is required from an accreditation standpoint to the depth that it looks like it's desired. Like the knowledge and about human injury, disease, deformity, symptoms, drugs. You know what I mean? That sounds like more of a nursing thing.
I would agree.
What? I'm not looking at that directly.
Number one, medicine and
Really?
Oh, yeah.
First of all, diagnosis. I mean, I don't know where you got this information, but that would never be something that a medical assistant nor an RN could do.
These are listed in the ONET under the medical assistant
Yeah, well,
as knowledge, skills, and abilities, and then these were the ones that were checked by the employers as important. I think that I agree. It represents a general kind of understanding, not to the level of depth that a nurse would need, or certainly a physician would need, or other highly skilled practitioner.
it just sets the bar high, I think. Which is, I suppose,
And I would also say that not all these are necessarily in, I'm sure, the accreditation or any kind of certification standards. So it's still going to be up to your organizations to decide what you want to instruct people on. We're just trying to give you guidance from the employers on what they think might be important. So.
Are there extra copies down there?
I have one whole set here, Fiona.
Do you want me to have copies made?
How many people do not have copies?
Why don't you give me the pack? I'll go have somebody make a copy.
Okay.
Or send it to us.
It will be sent electronically, yeah.
Maybe we read it wrong.
Have somebody make a copy.
Here's a whole set right here. So, I know that there's going to, we actually had this conversation, Fiona, with a couple of your folks, Julie and Linda, yeah. And so we know that this is not an exact deal here, but we're just trying to get feedback and provide, open communication channels. So. And you're from Cherry Street,
I
right?
am, and I had not seen this before.
That was the response I got from Cherry Street.
Yeah,
So
I did see this
you
yesterday.
might want to take a peek at that.
Yeah.
Yeah.
And I would more have agreed with the way.
Okay. So by the time I added,
Sure.
5 other organizations, you do tend to get, for instance, Tom's organization only had 4 or 5 in the knowledge, skills, and abilities each, but some organizations check more. So you end up checking. I don't know that there was anything listed on the ONET that didn't end up on the list somewhere. The ONET is an occupational network provided by the federal government, and they do the classification of jobs. And we're using that as the standard because all this forecasting and everything is, I know. Good thing it's got another year of warranty on it, doesn't it?
I think it kind of reflects the tension of what people are hoping MAs will do. And I know when I go into my office in an unnamed health system, they'll say, nurse will be in a moment. and it's not a nurse, it's an MA. And I'm always very proud to see that they're Davenport MAs. But I'll say that to them. Why are you being called a nurse? Oh, well, I can't get them to stop doing that. But I think there's some tension there because the industry would like the MAs to do more, and we have to be really careful that they're not out of their scope of practice. And so when I read this, the knowledge and information of techniques used to diagnose, what I see probably is more of the MA would prepare the patient and everything would be there so that when the physician comes in, he or she has everything they need to diagnose. So it's sort of a foresight piece.
Or the nurse practitioner.
Or the nurse practitioner, yes, of course.
BMP as well.
So I think there is some tension there because for a long time, people who are not nurses are being called nurses, and the MAs have been doing in some places more than they should. So I think that's really more of what some of this reflects, and I think we need to be careful of that. As we move to the next group, we're going to need to be careful. There's a clear line of distinction
Yes.
that the MAs don't practice out of their scope of practice.
Do MAs have to be licensed?
There is no licensure.
No, but there are certifications that are now being required.
There are certifications.
Certifications and registrations.
For the state.
But yeah, there's nothing that the state requires.
So it's by the employer whether they require an educational
In some cases,
certificate.
it's just been on the job.
Similar to many, I know Surge Techs, for instance, for many years was primarily on the job, and now some organizations I know, Mercy, is now requesting that people actually have that degree.
And nursing assistants as well.
Any other comments on the just the KSA scorecard? Again, we intend to do this with a number of occupations. We just wanted to start out, and it is a learning experience. And
So, Eric, sorry, I don't know where we are on the agenda, so I don't want to maybe I missed it. What will your next steps be with this then? What do you want from us? Where do you want to go with this?
so the question from Fiona is, where do we want to go with this? I'm going to ask that of the employers. We might be able to complete that discussion a little better after, or enhance it after we look at the scorecard too, because they kind of go hand in hand. I mean, the scorecard, report card is kind of an evaluation of, so how well are we doing? Oh my. And the KSAs are the kind of the content, and so we may need to tweak the content, I guess. There may be things that educators are just not going to cover on their side, but that's good because then the dialogue can help the employer know that, okay, this is what they're going to get when they step out the door and with their certificate, and this is what then we need to provide to that individual because it's always going to be, this is the way we do it here. You can have a medical assistant leave Metro and I'm not, this is just an example, okay? They leave Metro and go to another organization that has medical assistants, and they're always going to need to learn. So this is how we do it here, right? I mean, because there will be nuances and different things, slightly different practices. So I just think that that's a big benefit of this scorecard, is that, or not the scorecard, the KSA analysis, is that the employers are going to know what the people are going to come out of school, the different schools with, and then what they need to provide to them so that they can meet the standard when they are released to actually care for a patient.
From an employer perspective, I would answer that a little bit differently. This is a pivotal role in our physician practices. When we think about healthcare reform and we think about our business shifting from making money by keeping people out of the specialty side of the system. We're going to be dramatically growing our primary care and emphasizing our primary care. This is the pivotal role. This is like the RN in the acute care environment. And from my perspective, I'd like to have somebody at our next meeting from ACT, and I'd like to have an expert from physician practices. And I don't care whether they come from Spectrum or Metro or St. Mary's, or maybe we have some from each. But we went through an intense process of validation of the knowledge, skills, and abilities. And so we've got to clear up the confusion here between the education side and the employer side. We're very specific. Our physicians and our leadership from a quality perspective are very emphatic about what they want from MAs. Beginning, I think it's in 2014, all of our MAs at Spectrum and at St. Mary's and everywhere need to be certified to enter information into the electronic medical record to qualify for higher levels of reimbursement. Everybody's scrambling to get their people certified. And this is, the bar is being raised on what now I don't know why there's confusion in the language. I'm not clinical and certainly not that kind of an expert, but this is a business imperative. If we don't figure this out, in a productive way, it's going to have huge impact. And what we're more concerned about is schools keep, and I'm not talking about the ones that we are partnering, but there's all kinds of programs out there that keep cranking out MAs. And we've talked about this before, that is so unfair to those students who enroll and pay money to go through those programs and don't come out with the kinds of skills and knowledge and abilities that make them employable or allow them to survive and be sustainable. So we've got to fix this. It's a business imperative. And it's so I would suggest that we get some experts in this room who can answer these questions for us. And I'd be happy to ask someone from ACT who actually profiled these jobs. And the way that we profiled them, just so you're aware, there was a very rigorous process to identify what the knowledge, skills, and abilities were in advance. Information from the ONET, which is the federal database. I mean, it is the most reliable database. We then did subject matter expert focus groups with people in these roles to verify that these things describe what they do and what they need to know. And then we did concurrent validation with hundreds of employees who we put through assessments that are supposedly effective at measuring these KSAs. And then we now use certain of those assessments, which have been validated and are EEO compliant, in the hiring process. So this was done with a lot of science and rigor. So we should be able to put some people at this table that can answer this question of why is this feeling like it's disconnected? So
Did someone look at the public health code though? I mean, this is all. It should be.
And it was thoroughly reviewed with all the appropriate people. So I'm unclear. I'm just curious. I'll just be curious why there's some disconnects at this particular point. Well, we gotta fix that. We need to be on the same page because this is about sustainability of the business going forward, and we're going to dramatically grow our primary care in West Michigan to support the work that needs to be done on a preventative side under healthcare reform. So this is a critical topic that we shouldn't. We got to push this, and maybe we even need to do that sooner than waiting till November, if people would be interested in reconvening. But we've got the right people in the room. I'm just unclear why we have some disconnects in the information.
The report that Tom mentioned was handed out I don't know if it was the last meeting or the previous meeting. So it is available to everybody. If you've, I will include that in this packet. We're sending a sign-up sheet around, and so it's a summary of the formal report from ACT to Trinity or to Mercy, and that's been checked through all kinds of different, the CNOs here, and Jim Scharf, who's like a EEOC expert in Washington, D.C. It has been checked 6 ways to Sunday as far as compliance, being legal, enforceability as a hiring practice, all that kind of stuff. So we will provide that report to everybody again.
I think there's another practical piece to what Tom's saying is we employ folks that I'd be interested in asking the operational side of certified versus non-certified. Do they do something different in practice? Do we pay something different in practice? And I think that would be interesting because that goes to kind of what Tom's saying. Are the expectations different? Are they trained different? Are the outcomes different? And if not, how do we back up from that and train them appropriately or hire them appropriately? And how do we feed them into the system appropriately? Is their turnover different based on OPC? So I think there's a practical part of this too. The science is all great, and we need to have that, but the practical piece I just think is interesting because I think if you're the provider, you probably care less as time goes on and you care more about performance. And I see them jumping in front of buses for the ones that they're close to. Because in the small practice, you become very close to your MA, right? And so you live and die by that person and how they room the patients. And I mean, we hear it all the time. I don't care what happens, I'm going to live and die by this person. And so how do we reproduce that, whatever that is? And so how do you bottle and sell that? And I don't know that at the end of the day if they're certified or not. So if it's not, what is it? And again, if I'm looking at re-recruiting people, that's what I want. And so how do I do that? And again, I don't know that the art and the science meet ideally there. But we talk about that all the time, and that's the hard part in the recruiting and then re-recruiting. So that to me is just the other practical part that I think is interesting. Are we paying people differently for those all the way down to the job codes, and how are we doing that? And it's probably similar in structure, and I'm not sure it's the same in application.
And I can tell you too, because we have introduced so many RNs into the physician practice side of the world. We're introducing a lot of MPs as well, but we are very, very, very careful around everyone not ever working out of the scope of their practice. And I know Metro's the same way as Spectrum as well. So so maybe we've got to just go back and recheck the language and so on. But we agree with you. No one should be working outside the scope of their practice, and no physician should be using someone out of the scope of their practice. And I'm with you. I wish we quit calling them nurses when they're MAs.
So I went into the ONET. This is the federal system, and I went to the knowledge section, and you'll see that the second highest ranked knowledge is this medicine and dentistry. So this means that this is a result of thousands of jobs across the U.S. being, thousands of medical assistants across the U.S. being evaluated for what are the most important knowledge, skills, and abilities. So maybe we also have some contacts at the ONET. So we can ask some questions about that. I mean, this may be the level of information. The person needs a rudimentary level of knowledge about.
It may just be semantics.
Yeah. So.
What does ONET stand for again?
It's the Occupational Network of something. Yeah. It's the ONET online. It's yeah. This is the main website. It's onetonline.org. And it's a wealth of information about, in fact, in the career coaching videos I'm talking about, the self-study, there's several different chapters just on how to navigate and find things in the ONET that benefit you. And it would benefit employers as well as individuals. So it's part of the reason a lot of Tom's OTE people went through the training was that you can learn about this.
Is this replacing the dictionary of occupational titles? That's what I thought.
Yeah, that was the old terminology for it. Okay, so I'm going to circle back with Tom, and we're going to find the right people we need to get at a follow-up meeting and decide when we want to convene that. And probably what I will do is use this email list that I'm passing around to make sure that everybody that's here today knows about that meeting. So, you know, if this particular topic of discussion is important to you, then you will know that you need to have somebody at that meeting, and we'll be very careful about scheduling that meeting so that the appropriate people will be able to attend. In fact, we'll use a doodle calendar to make sure we get the most optimal date for everybody to attend, because it is an important topic. And we'll want to do the same with the other occupations. So this is all a learning experience. This is great. I think it's good that we've been having this discussion. Anything else? I'm already got my page here up on the next topic, but anything else on the KSAs? All right, then the report card. We had sent out a preliminary report card earlier. The information on the earlier report card was for January 1st, 2012 through the end of March 2012. And what we wanted to see was in that 1 quarter period a year later, how many people were still employed. That was the crux for the report card. There are 2 benefits to this report card, at least, maybe more. One is this kind of idea of how many people from different organizations are still employed a year later. And then the second thing is Tom has graciously allowed us to share his information. So this is Mercy Health's report card. The middle section there describes Tom's results. And then on the right, it shows the right hand, or the right third of the page shows everybody's collective results. So even if you don't have a lot of results on the schools, you at least have kind of a retention percentage that you can compare to your peers throughout the community. And you can get an idea, a little bit of an idea, an indication of, so how are your hiring practices? Are you using a strong enough targeted selection interviewing technique with people? Are you asking the right questions? Are you hiring the right people with the right backgrounds? How do you stand in that? Because we all know, even a minimum wage job, what's the SHRM estimates, that's a huge cost just to replace, I don't mean just, but to replace even a minimum wage position costs the organization a lot of money when you add up all the opportunity costs. So we feel this is an important indicator, and we'll need to dig deeper into this and make sure that we do an even better job. Now, this particular report card is missing some information. We got a couple of our organizations got a little mixed up on what time period they were reporting. So one large organization reported on the schools and the number of people they hired, but they didn't report on how many people are still there. So we're collecting that information. Another organization gave us the period for 2013, not for 2012. So we're not all the way up to 2013 yet, because we're trying to measure a 1-year period of employment and the consistency. So I know it's been a little confusing as we get the instructions out to people. They keep saying, well, don't you want to know, how many people we hired in, April of 2013? And we'll say, no, not yet. We want to know how many you hired in 2012 to see if they're still there a year later. So, we will send a more complete report card out. I'm confident we'll have all that information by the end of this week or early next week. So you'll get an updated scorecard at that point in time. You can see that there's some interesting variations in an employer and their percentage versus the whole group of employers and their percentage as far as, the retention rate. So we know that, particularly if you're talking small numbers, there can be all kinds of reasons why a person leaves. It may have nothing to do with the educational institution. Illness in the family, husband or wife gets transferred and I have to get a job in a different city. I mean, there's just all kinds of things that happen. So we decided we would start off with a simple measure and start to measure it, get some consistency, and then try to increase the efficacy of that particular measure. And we've got a PhD statistician helping us and an actuarial helping us, and Andy Catlin, my partner, does data science for the National Football League, and so we got some really good people on this, some really smart people that will be able to help us with this. And the PhD teaches statistics to PhD nursing students, and he works in a hospital, so he knows healthcare very well.
From an educational standpoint, it seems like what I'm hoping when this rolls out is that I can sort of determine what best practices are with the educational institutions. But I hear what you're saying about it could be any reason for leaving, so it may be not as helpful data for that as I had hoped.
Initially, but again, we want to start off with something that was measurable and people could easily report. And we're going to have this discussion in a few minutes because some people were able to do this for medical assistants because the numbers weren't so great. But there are organizations that in their HRIS systems don't keep track of what school the person got their certificate from or even graduated from. So that's going to be problematic. I mean, I know Tom's got 1,700 RNs that work here in West Michigan, and if you don't have a field in your HRIS system, that's going to be hard to manually track all that information down. And so we're going to have to talk through that a little bit, and that'll be part of our discussion for the next occupation. So, but we do want to try to improve the measures so that and how we're going about doing it. But we've got to walk before we run. So, other comments or questions on the report card? Everybody everyone in the Healthcare Employer Council gets their own report card. No one else sees anyone else's data, except that Tom has allowed us to share Mercy Health's data with people, so that you do get an idea of what the individual data looks like and then the group data. So,
Just thinking through it. Practically, I don't know how you get to this measurement, but there is that difference between positive turnover and negative turnover, and where they exited for performance reasons or unexplained versus, my spouse got a job out of state and we're relocating, or I promoted, or I went into a different program further in my education. I'm assuming the numbers represent clear exits from the organization and not just exits from the position. So at least it means most people, if they're gone within a year, that was most of the time negative turnover. But I think it's a valid point of, it's not always the case.
Actually, just looking at voluntary versus involuntary departures, I think a big difference if you could track those departures. Involuntary termination might tell you more than voluntaries.
and I think we can add that granularity as we get more practiced at this. But I think there will be some other really fundamental things that we'll need to get in place, like an HRIS field to track school, if we feel that's really important information to, if the employers feel that's really important information to track.
Do we know what percent of the MA population is being reported by these employers? Or is there no way to calculate that?
Total population in the marketplace?
Right. So there's a lot of independent physicians that probably employ MAs that, aren't submitting data.
Mm-hmm.
I'm curious if we looked at, is this half of them or?
I think that I'm just thinking out loud. We might be able to get a read on how many different programs there are and how many graduate each program to kind of get a sense of the population. And then we have to make a bit of an assumption that the majority of those people remain in the market. We know not all of them will, but I'm just thinking that for this kind of a certificate, you're going to have a pretty high percentage of people that stay in West Michigan and go into that field. But I think that might be the best way to get a feel for what is the total population of MAs in West Michigan. We can also go back to the ONET and try to figure that out and the DLEG data. I'm not real confident right now in the DLEG data. I mean, because I was working closely with your organization, I knew how many RNs you hire per year or new, and that was more than DLEG reported for the whole region. So that information is an extraction from federal government information, and by the time you break it down to a region, it really breaks down fast. So I'm confident maybe at a state level of that data, but not for the West Michigan market. So I think now I would say that as far as the larger institutions, we should have a substantial portion of the population because we have Spectrum. Now Metro, I don't think Metro has MAs. Yes, you do. Yeah. So we have Metro, Spectrum, and your organization. Chuck, you don't have MAs, do you? You have.
We've got MAs in our physician office.
In the physician offices. So we may want to come back around at that. You're not in the data right now, but. And then we have Cherry Street has a significant number. So I think we have a pretty good representation of the numbers. And I did confirm with Spectrum that when they're reporting these numbers, they're reporting all of their facilities, not just the Grand Rapids facilities. So if we're not looking at physician practices, which could be significant, we've got a pretty good slice of the major size organizations. Because with you, we've got Muskegon, we'll have Holland, and then Grand Rapids pretty well covered. Anything else on the scorecard at this point? This will change quite a bit when we get more data. And are you surprised by this, or is this what you? I'm not talking about the numbers per se, but as a report card, what people were expecting. Were you pleased with it, displeased with it, or can we change something and do something different?
I mean, this is all about Grand Rapids. I mean, I would love to see 100% roll calls. So from I'm doing a deep dive in terms of the data, that's a good thing. It does, just a related thing from an educational institution perspective, knowing where our students are within a certain time period is always a good thing from our perspective. We don't always hear back. So if this is something that I'm just thinking of down the road, how can we work with your scorecard system to validate our students working in the field post-graduation? Because as we get pressed for more placement data and information, how do we stay attuned to your reporting? We bug students, but maybe we need to be bugging employers. And I'm saying that very facetiously, but somewhat truthfully about where are we going with this data so that we can, and making sure that what we're reporting is absolutely sort of true. So that's a bigger picture perspective that I see out of this data in the future.
Mm-hmm.
Well, part of our accreditation information is that graduate survey that then drives the employer survey. And so how can we partner up to get the information that we need from our accreditation body as well as being meaningful for the other side?
Mm-hmm.
Well, from my perspective, we're more than willing to share favorable versus unfavorable turnover. And if we shared it even at that level, favorable being they lack the skills and abilities or the behaviors we need to perform in this organization, and unfavorable was they were outstanding performers and for whatever reason left. I don't want to get into all the sundry reasons why people are, but maybe if we categorize them at a high level, that would be an important set of data. But when
If
this,
they left to enroll in a RN program.
That's a good
That's a
thing.
Favorable.
That's great.
yeah,
And our accrediting body looks at that as positive placement if they're going on further into the healthcare.
Step in their process.
Right.
but if we're finding that there's a common theme that there's a particular program where we're seeing more students lacking the knowledge, skills, and abilities to perform satisfactorily, how can we work together with that organization to raise the quality of the curriculum so it is more aligned with what we need? You know, this is never intended to exclude or embarrass any particular organization. It's how do we make sure, and I believe that if we can get to a point we can implement career coaching as part of your selection process for students, so we're making sure we're putting students in these programs that are ultimately really want to do this type of work and are well matched with it, we'll be further ahead as well.
And I think this also comes back to the point that in our advisory meetings for each of our programs, we need to have our area employers on there so that we're aligning ourselves with our accreditation as well as what our employers need. And so that we can keep the numbers stable. If you hire 4, we'd like you to keep 4 based on us providing a quality education. If they choose to leave for relocation of the family, something else, that's outside of our control as an educational facility and as an employer.
One curiosity I have, taking it from a macro perspective, is how that 59 hired number, so if that's in 6 months, I don't know what represent, how much of the MA population these employers represent as a community, if it's 80%, 50%, whatever, but I wonder how that number compares to how many MA student grads are coming collectively out of the educational system. It kind of gets to Tom's point earlier of if we say, well, there's 59 hired in that period, but the educational system put 400 people in the marketplace in that period. Or if the educational system said we put 30 people in the marketplace in that period. I would just be curious what that comparison is, knowing, are we flooding the market or is the market needing more?
It might be helpful also to know how many, like we said earlier, how many employees that you do have in that MA role. So that we get a percent of what your turnover is or what your hiring rate is.
Yes, and we, maybe that's a data set we could collect is, how many MAs we each employ. Because
So-
we employ hundreds.
I know you keep that, Tom keeps that information, and they keep it monthly. They know exactly how many MAs they hired and how many they turned, and they know if it's favorable or unfavorable. And so there are techniques for doing that, and we can employ some of those techniques more broadly just to collect that data from you. It would be one of the additional sophistications we could do in this whole measurement area for you. So
That might be good overlap with what Talent 2025 is doing.
right, with the forecast, we want to meet with that forecast then, because you're right. If we don't want to flood the market then either,
But you don't want to.
but we don't not have enough. Yeah, and we don't know that today. We really don't for most occupations.
That's where the career forecasting, job forecasting is so critical. And so if we, working with 2025, Talent 2025, can master that, be giving accurate data to you, you can be enrolling just the right number of people, keep the supply chain full of qualified and competent kinds of individuals for us to hire. The more exciting opportunity also is in the next job that we're going to talk about, which is RN.
So, great lead-in, Tom. Thank you. Because the next discussion is, we had a discussion at the last meeting. So what should be the second occupation? And our goal is to have the preliminary reports done on 2 occupations this calendar year. And the first one was MA, and the second one we discussed at the last meeting and seem to have a pretty good consensus on was RNs. Now, it is a totally different animal than MAs, although I think the MA population could rival RNs at some point in time in the future, kind of based on some of the things Tom was saying about the shift in the way healthcare gets delivered more in practices and clinics than in the acute care. But still, it's a very large population. It's I think the kinds of roles are broader than in an MA, because there are surgeon nurses and psych nurses, outpatient there's all kinds of different nurses. You may have some of that in the MA. So anyway, and then there's the sheer numbers, and then just the ability to report, as I described earlier. Not everybody has that in their HRIS system. Again, there are two major benefits to this report card. The one is has to do with sheer how does an organization rank against the overall market on turnover? Are you better than the market, or are you doing worse than the market? And if you're doing worse than the market, all it is an indicator that you need to investigate your practices and bring in whoever you work with to try to help you improve that, because you're lagging in the marketplace, and we want everybody to have an excellent ability to hire the right people and keep them. Then, of course, the other benefit is the reporting on for the different educators. So we can kind of take it a step at a time. Where if we don't have the educational institution information, we still should collect the data, because we believe it's very beneficial. And then what we would like to do, and Andy and I can do this, is try to, because Andy is a top-notch IT guy. He knows all kinds of systems, and we can come in and we can maybe advise your TIS staff on how they might add some kind of a field to be able to track either the source of certificate or the graduation school, if that information is not being kept. Because on nursing, that would be, I think, just about impossible for a large organization to be able to do manually, as we did on the MA. So I'm going to open that up now. This is more for the employers and the educators to talk about. Nursing, is that the right pick for our next occupation to study? And I believe that it would impact more members of the Healthcare Employer Council than MAs, because I'm guessing almost everybody has RNs in their organizations.
I think I would affirm that's particularly what intrigued me and interested me in this agenda, because I know several of my colleagues in the post-acute network are a part of this and invited to this, but we simply don't use MAs. So in the post-acute system, MAs are virtually absent within the post-acute system, but RNs are the core of our post-acute system. So we represent a significant population of RNs. The post-acute system is also growing tremendously and expected to grow, in our need for RNs will grow along with it. So we're invested in this. I would just affirm from that perspective to be absolutely want to participate and be involved in this. And I speak on behalf of several of my colleagues in the post-acute network too.
Great, because one of our objectives, because we have been very focused on acute, but we want to be in that post-acute, is to do something meaningful that invites you to want to participate. But we know we have to have some involvement that benefits you in order for you to spend your precious time coming to participating. So thanks for that information. And if Craig and I can be of any assistance in even driving around and meeting with people, just to give them, I hope this technically turns out well enough so that it's something we can send to someone. But Craig and I would be happy to go out and talk to folks and just explain more about what we're trying to accomplish and give them examples of the different reports.
And I think the intention, at least on our part, would be to move on to the PCAs and CNAs after the RN. So we're really looking at those individuals that have the most immediate contact and impact on the patient experience. And so, and I would think some of those would resonate with long-term care. With the CNA is probably a pivotal role for you as well.
Yeah, CNA, the resident aide, the home health aide, but
Well, yeah, whatever we call them, we call them PCAs here in the hospital, but you know, part of that care team, that's another really critical role that we need to be taking a look at, making sure that they have the knowledge, skills, and abilities to be successful in those roles. So, but I can tell you for CHE Trinity, it would absolutely be the RN would be absolutely critical. We move on to that.
I think RN is the next logical choice. In the acute care setting, it's the most highly populated job classification we have. So it certainly makes sense to me.
So when you say RN/nursing, are you just talking RNs?
Yeah. This group would maybe be on the way on this pattern. I would think we would. And we're employing more master's level nurses in acute care. So I don't know. I'm not the expert there. Would rely on academia and others, and maybe check with our CNOs. But you know, what's going to be the best way to collect the data? I can tell you that we record it in PeopleSoft when we hire people, so it's and we record all certifications as well, so we have all the data. But again, if we're talking about new hires going forward, I don't see that to be a burdensome set of data to begin collecting if you historically have not collected the program. And you may find your nursing departments have been doing that, collecting that information. But we're only talking about new hires going forward, not collecting that the entire workforce.
Right.
So,
So I don't know a lot about, on that clinical side of it. They tell me they need a psych nurse. I say, what kind? What am I looking for? So if you're an RN, can you have a specialty within an RN, or is it just straight RN and then whatever experience?
Right, yeah.
Right, that's the way.
Experience, right. It is experience, so it wouldn't,
So it's not
a new grad wouldn't
Yeah,
wouldn't have a specialty.
But there are certifications that you can get
With
experience and then testing, and then you obtain those credentials.
for different categories.
but where we are the educational programs
Absolutely.
that they graduated from, I can tell you we have an intense interest in looking also at certifications at some point, and which certifications also link to stronger retention, because we reimburse heavily for post-secondary certifications, like critical care and OR and all those areas. That is an important piece too. But we could at least walk or crawl before we walk and start and agree to do that. I think it could be incredibly valuable information.
The question is, what would the process be? We would initiate the same kind of activity on RNs that we've been doing on the MAs, and we would start almost immediately. We might need to convene with a couple of folks just to make sure that we're just doing the description of the request for information properly. Because, again, Andy and I have worked in healthcare for a long time, but we're more like Tom. We're not clinical, and we don't know some of the variability in nursing. And I mean, I know that there are 2-year degrees and there are 4-year degrees, and there are a big emphasis on masters and PhDs, and then that a lot of organizations are starting to look mostly just at bachelor nurses and not the, some are not looking any longer at the 2 years. So, but that's about all I know. So I would need a little bit of help so that we can structure the questions correctly and set the reporting up correctly.
I guess the question I would have is if the KSAs or the RN, are we looking at arriving at a single set of KSAs for the RNs, or do those vary depending on somebody's primary care, acute care, or post-acute environments, or is it come up with a single list of KSAs, or is there a differentiation?
We will again start with ONET, and ONET probably has at least 6 or 7 different kinds of RNs listed. So I think there's a good start on that in the ONET as far as a surgical nurse versus critical care nurse versus an ER nurse or an outpatient nurse. We might have to enhance that, and we may have to create our own category and do our own KSA survey for that particular category. It may be that post-acute RN is not adequately described in the ONET, so we want to develop something for our marketplace.
It's kind of that tug of war, though, if you don't want to measure it 15 different ways.
Yeah.
You want to arrive on whatever that
We
right.
profiled it one way here at St. Mary's.
It was a huge discussion, yeah.
Yeah, it was a huge discussion, but, we all pay them differently, whether they're an AD or BSL, we don't pay them differently if they work in OR or critical care or trauma services. But we got to one definition of the KSAs.
So I say we would start immediately, but I think it would have to be with some discussion around some of these topics and some agreement on what's the standard going to look like, and what kind of outcome do we want to see. And I would want to include Andy in those discussions as well, my partner. He's the one that asked the really good questions about data sets and information. So.
And I think it would be good if we made sure we were fully aligned on all those definitions before we launch. So we'll do a good job of that. Again, we can put some rigor into that process to make sure the education and the healthcare employers agree on those terms and definitions, and so there's credibility to the data we collect. So it means something and is useful.
I would suggest if we could get some concurrence that the CNA, the personal care people actually be given kind of a nod at this time so the thinking can start already, because that's going to be by numbers also a huge thing, rather than wait.
I mentioned earlier that we had sent out a report on the MAs to everybody that Tom's organization had prepared. And I don't remember, you had 5 reports at that point in time. I can't remember if we sent out all 5. You had environmental services, nutrition.
I don't think we sent them all.
But we could probably go ahead and do the RNs as well. So you'd be able to get a look at what the result of the job profiling process that Tom's organization went through, which was really exhaustive and extensive. You'd be able to get a view of the summary description of that. And that would hit some of the terminology part so that we could maybe use that as a first step to say, okay, are we comfortable with this terminology? And then all we're doing is adding some of the other points from the ONET that Tom's organization says, well, our RNs don't get involved in that in particular, but other organizations might use some of those topics from the ONET.
Maybe this was already discussed, and not to confuse things, but is anybody using LPNs, and do we care about that? That's a long-term care that we use a lot.
We don't use them in
Right.
We use them in primary care.
Yeah, the home care.
That's the backbone of home care, assisted living, skilled nursing.
I think it's one that we should be careful of and have more conversation in primary care setting, because we use them in primary care, but they're often working in the role and in the scope of practice of an MA.
Correct. Yeah.
So we may, out of respect for them, I know in our system we pay them as an LPN, and that's,
I understand.
And I think from a measurement perspective, the RN is the more difficult, more critical position for us.
getting more so.
So I have LPN on the list.
I know there are programs here in Grand Rapids.
Any other discussion then on the RN? We have a couple of action items to do, probably well before the next meeting, so we'll be working on both of those. Any other things that we want to talk about? That's basically the agenda for our meeting. Tom, I don't know if you have any closing comments or if anybody has any additional questions.
Other than additional questions, and thank you all for coming today. Our next meeting is scheduled for November 14th. It may be at a different location if we hold it here at St. Mary's, but we'll try and do something in the interim so we can move this conversation in the MA along. But how significant can the work be to start coming back in November around this issue of the RN?
I think we should have a meeting before, long before. We should have a preliminary report card by the next meeting, would be my goal.
Okay.
Even if it's not what the final one's going to look like. Just as we did on this MA, we sent a report card out probably halfway between the last meeting and this meeting. It was a preliminary report card just with partial data, but we kind of got a sense of what it was going to look like. I would say we want to do the same thing on RN and have a preliminary report card, look at 6 weeks from now or so. And then we come back in November, we'll have an even more complete report card. And then the goal would be by the end of the year have MA and RN substantially complete, although I believe there will be follow-up assignments on both of those occupations, and then we can prepare the other occupations we discussed for next year to do the work on those. Does that sound like a good, I can put together a little operational project plan on what that would look like so everybody sees that. Thank you all very much, and you will get all this information by email. And I hope the the recording comes out okay so that you can hear most of the conversations. So thank you.
The only last thing I have is what's the new reproductive and what would have made it more effective?
Yes, thanks.
Are there things that would have made this meeting more effective that, other than the technology glitches that we have when we started, we'll make sure that that's all, we'll get here earlier next time so that doesn't disrupt the meeting. I apologize for that. Anything anybody has? Okay, thank you.
Eric?
Actually, I have done that here more often.
Outside this.
You might want to mention the measurement.
I'm wondering, is there, if anything's going on in other areas? Are we so far ahead of other areas?